So we're so excited to welcome Sarah Chappell today. She operates legal clinics at Mount Sinai Hospital and Montefiore Medical Center and is the coordinating attorney for LegalHealth's home care project. Sarah provides counsel and representation to patients in diverse areas of law, including immigration, housing, Medicaid, and public benefits, as well as Social Security. She previously worked as an attorney at the Center for Independence of the Disabled, specializing in Medicaid and home care issues. Prior to this, Sarah clerked for Justice Cynthia Kern of New York State Appellate Division. She is cum laude graduate of Duke University School of Law. And then with that, I'll pass the mic over to Sarah. Thank you.
Thank you so much, Harmony, and thank you everyone for attending. I'll just be sharing my screen now so that you can all see the PowerPoint. Okay, great. So today we'll be going over some home care basics and also the most important changes that are coming this year to home care and Medicaid. LegalHealth is a division of NYLAG, and we provide legal assistance within the hospital or healthcare setting. We're a medical legal partnership model. Today's training objectives are to learn the basics of financial and medical eligibility for Medicaid-funded home care with a focus on changes happening this year. To review the new independent assessment process for home care, which has expanded to more categories of home care applications. Learning to assist community members seeking long-term care in their own home, and also reviewing options that community members have when their existing home care hours are not sufficient to keep them safe at home. So starting with a broad overview of the changes to Medicaid and home care happening this year. So firstly, a change that already was mostly implemented last year is the independent assessor process for personal care services and also consumer-directed personal care services. And since this was implemented last year, in May of last year for standard timeline requests for home care and for MLTC enrollment, and then in December for the immediate need process and expedited requests, we have already some information about how this process is working or is not working for community members. So we'll be discussing how to respond to denials. Now, this has not yet been scheduled or phased in for annual reassessments for home care, like from managed care plans or from HRA, or for requests for increases in hours, or for nursing home or hospital discharge requests. As of January 1st this year, we have some new income and resource limits for Medicaid, which are going to help a lot of patients. We also have coming the end of the public health emergency COVID, the moratorium on the closure of Medicaid cases. So we're going to have renewals starting up again for community members. And the first Medicaid discontinuances are expected for July of 2023. So we'll go over some steps of how you can assist community members with their renewals. And then coming up next year, just to a slight preview, even though we won't be discussing this very much during this presentation, are some changes to medical eligibility for home care and also a new home care look back for MLTC enrollment and other requests for personal care services. So that won't happen until 2024 at the earliest. So we won't be focusing so much on that change. The 2022 New York State budget made some great increases to Medicaid income and resource limits. So the budget raised the Medicaid income eligibility level for people 65 and over and people with disabilities on Medicare to 138% of the federal poverty level. So we'll go into what that limit actually is in a few slides, but just wanted to inform that that is a huge increase from what it previously was. The budget also increased the Medicaid asset limit or resource limit for that same population. It didn't eliminate the asset limit, so there still is a resource test. However, it's a much increased asset limit, which will help a lot of patients. And it also raised the income limits for the Medicare savings program as well at the same time. And these changes were effective January 1st of this year. So we won't be focusing on the Medicare savings program so much during this training, but if you see this chart, there's a big change to the Medicare savings program landscape in 2023, and that would be the elimination of the SLIM-B program. So now there's only two programs, QMB or QIMB, which is set to 138% of the federal poverty level, same as Medicaid. So the single income limit would be $1,563 per month to qualify for that program. And then the other program would be QI1, which has a higher monthly income limit, and that is $2,107. You can have QIMB and Medicaid at the same time. QI1, you have to choose QI1 or Medicaid. You have to make a choice, but essentially Medicare savings programs do help patients with a number of savings for Medicare. For example, payment of premiums and also protection from balance billing. So before we go deeper into these changes, let's talk about some basics of the Medicaid landscape. When it comes to Medicaid, you can think of there being two buckets that people could fall into to qualify for Medicaid. So there's two sort of major population groups when you're thinking of, is someone eligible for Medicaid? So the first group is the MAGI population. Those are people who are under 65, including if they're disabled but not yet on Medicare. Parents and caretaker relatives, even if they are elderly or Medicare eligible, and pregnant women and children. These income limits have been 138% of the federal poverty level prior to this year. So it was always a higher limit than non-MAGI group, which we'll talk about next. So their income limit for this year is $1,563 for a single person, and then depending on the household size, that income would go up. Pregnant women and children have even higher income limits, and for MAGI Medicaid, there's no resource test. So you can have any amount of money in the bank and still qualify for MAGI Medicaid. The other major bucket or population group would be non-MAGI, also called DAB Medicaid sometimes, and that stands for the disabled on Medicare, age 65 or over, and blind individuals. It's possible to qualify for non-MAGI when you're over the income limit. It's called qualifying with a spend down. The income limit for 2023 is now the same as for the MAGI population. So it's now 138% of the federal poverty level, or $1,563 for a single person. It's $2,016 for a couple, for two people. And then pregnant women and children still have higher income limits if for some reason they're in the non-MAGI group. And as I said before, the resource limit hasn't been eliminated, but it has gone up to $28,133 for a single individual. Now, these numbers that I've given you, they're the 2023 numbers. However, they're based on the 2022 federal poverty level. And that's because the change hasn't been made yet to update those to the 2023 federal poverty level. That will happen a little bit later in the year. And at that point, HRA will release the new numbers and it will go up to around $1,677 income limit for a single person. So So let's talk about what spend downs are. So non-Magi individuals can qualify for Medicaid with a spend down, which can also be called a surplus. Now, the spend down is simply the amount of income that a person has over the Medicaid income limit. So we're going to go over a sort of sample Medicaid budget on the next slide, and you'll see a little more what I mean by that. So individuals can activate their Medicaid by paying in their spend down to HRA, to the DARB unit, or they could submit medical bills to HRA to meet that spend down. However, there are some special budgeting rules that could apply to help certain individuals qualify for Medicaid without paying in their spend down or having to submit medical bills each month. So here's the basic budgeting framework that HRA would use to calculate a Medicaid budget. So you start with gross income. So instead of taking out taxes, union dues, child support, etc., you use the gross amount of income from the person. And then there are a few deductions that HRA would apply. You get a $20 per month deduction, whether you're a single person or a couple, it doesn't matter. It's $20 a month. You get to deduct any health insurance premiums that you pay, like a Medicare Part B premium, a Medigap premium, or a Medicare Advantage premium. There's an earned income disregard if any of the income comes from working. And then also there's a special housing disregard if the patient was in a nursing home or adult home for 30 plus days and then is discharged to the community with home care. They get a special kind of allowance for that. So after taking the gross income, deducting any of these allowable deductions, you have the income that Medicaid is going to use to calculate the spend down or surplus based off those income limits I gave. So here are some of the special budgeting rules I referenced earlier. So besides meeting the spend down with payment of the surplus or submitting medical bills, some patients can use these strategies. So the first would be spousal refusal. So if one member of the couple needs Medicaid and has a relatively low income, but their spouse has a high income that would prevent them from being Medicaid eligible, that spouse can refuse to financially support the patient's care, and the patient will be budgeted as single. Now, it is recommended that they discuss this with a lawyer first, because they have to sign a form that basically gives HRA the right to seek collection of the amount that they're spending on the patient. So they should really get some legal advice before doing this. The next rule is spousal impoverishment. This is a special budgeting rule for married couples where only one is receiving long-term care services like home care or nursing home care. And this allows the patient to qualify for Medicaid with a higher income and resource limit. And the idea is that just because one patient needs to be in a nursing home or needs home care, they don't want the other patient who doesn't need that care to become impoverished or lose their home. So it gives them a higher income and resource limit. Now, this strategy cannot be combined with the next strategy, which is the pooled income trust. So the pooled income trust, NYLAG helps many patients create these trusts. And essentially the surplus amount of excess income is placed in the trust each month. And the money that's placed in the trust can then be used to pay the patient's living expenses, like rent, utility bills, etc. Just about the only thing that they can't do is send the money to the patient in cash. So here's a case example. Branson is a disabled senior living alone with long-term care needs. His income from Social Security and his small pension is $14.20 per month. And for the past 4 years, he's been using the pooled income trust to eliminate his Medicaid spend down. His healthcare providers are concerned that he's losing capacity and is going to have trouble managing the trust or like directing the trust, right, which bills to pay. And he really has no one in his life to help him. So I'll just give you a second to decide how will the new income limits help Branson, and will he be eligible for Medicaid under these new income limits? So luckily, with that new income limit for 2023, Branson will be fully eligible for Medicaid with no spend down, even if he gets rid of his pooled income trust. And so the way pooled income trusts work, it's you can close the trust at any time. So Branson could request a rebudgeting from Medicaid, become eligible with no surplus, no spend down, and then close his trust so he no longer has to worry about managing that trust. HRA will be starting up the Medicaid renewal process once again, now that the COVID health emergency has ended. So there's a few things that you could do to help clients get ready for renewals and also to request rebudgeting under this new income limit for 2023. So firstly, it's a good idea to make sure that the client has their updated address registered with HRA so that they'll receive their renewal paperwork in the mail, because those renewals are going to start in April. And if they don't have an updated address, it may not get to the right place. So to change an address with HRA, you can use Form 751K in New York City, and the link is provided in the PowerPoint. The other thing you could do is make sure that if the patient receives the Medicaid rebudgeting mailing from HRA, to help them fill that out and send it back in. So HRA is going to be sending a one-time mailing with the MAP 3190 form and the MAP 3190A forms. So this is basically a letter that is going to allow the patient to say, yes, I want a budget review under the new 2023 standards. And so if they check the box and attest to their income in 2023, they'll send that letter back. It's important that they send it back in the envelope that comes with the letter, because HRA is going to have a certain process for scanning and sorting all of these requests that they're receiving. And if it's not sent in the right envelope, it might not get to the right place. And then HRA should rebudget the patient with the new 2023 income limits. Consumers can self-attest to their income for 2023. It's not necessary to document it with like a Social Security award letter or anything like that. So now we'll just discuss some home care basics. So home care is assistance of a personal care aide with nutritional, environmental support, and personal care functions. And this can be provided through personal care services or consumer-directed personal care services. Now, PCS, as it's called, is home care with a traditional agency. CDPAS, the Medicaid recipient chooses their own aide, most often a family member, not a spouse, that they want assisting them. And both services are fully covered by Medicaid. Now, today, we're mostly talking about Medicaid-funded long-term home care. Patients who need short-term home care might be able to receive that through Medicare, but only Medicaid covers long-term home care. So here are a few technical terms that you find in the Medicaid and home care landscape that I think it would be helpful to define. So first, activities of daily living include bathing, dressing, feeding, toileting, anything really related to the patient's physical body that they need assistance with in their own home. versus instrumental activity of daily living are what we might think of more as housekeeping or chore tasks, like shopping, cooking, housekeeping. And this will become important when we talk about whether someone qualifies for home care and what the new assessment process looks like. So to go over some different types of managed long-term care plans. So the reason I'm covering this is because different types of plans have different appeal and fair hearing processes. And so it's just good to get this distinction out of the way now. So one type of managed long-term care plan is called partial capitation MLTC plan. And this is a plan that just covers Medicaid, home care, and certain ancillary services like vision, dental, and hearing. It doesn't include the patient's, medical doctors, specialists, etc. So patients who select this type of plan, they can keep their original Medicare or Medicare Advantage plan that they're already in and keep their doctors and their networks intact. Now, the other type of plan is called dual eligible Medicare Medicaid plans. Now, there's a few different types of this plan, but generally they all combine Medicare and Medicaid coverage and cover all the Medicaid and home care services a patient might need. So you obviously have to have both Medicare and Medicaid to enroll in this type of plan, and you have to stay within that plan's network for all of your services. And just a note on home care and hospice, certain populations aren't eligible to enroll in managed long-term care plans, and that includes current hospice patients. However, if someone's in an MLTC plan, they can enroll in hospice. So it kind of, goes one way and not the other. So now let's talk about the new home care assessment process. So I want you to generally think of two different, again, buckets or populations of people who need home care. So one would be people who need home care really urgently, like tomorrow, and they can apply for immediate need home care to New York City HRA. The other population generally wouldn't need home care immediately. They can wait a little longer. And their general strategy will be to enroll in a private managed long-term care plan, the kinds of plans I just went over. So the immediate need home care application process, as you might guess from the name, is generally faster than the normal MLTC enrollment process. And the patient, their power of attorney, or any authorized representative they choose can apply for home care and guide them through the new assessment process. So just a word about immediate need applications. So if the patient needs home care urgently, they can submit an application for immediate need authorization to HRA in New York City. This application should consist of the attestation form where the patient says, yes, I need home care right now. The M11Q form, which is the doctor's order for home care, a HIPAA release, and if the patient doesn't already have Medicaid, they can apply for Medicaid at the same time that they're applying for immediate need home care. Medicaid eligibility has to be decided within 7 calendar days of the application being submitted. And then the service assessment must be completed within 12 calendar days. So this is much faster than the typical managed long-term care plan enrollment process. It's a really great option for people who need home care urgently. And so even though people submitting applications via this process are still subject to the new assessment process, I'm going to describe in just a few slides, they still submit their initial application to HRA, not to the independent assessor. And the independent assessor does have to work within these timeframes. So they have to do the assessment quickly. So the new independent assessment process that I'm going to discuss applies to not only the immediate need request to HRA that I just described, it also applies to MLTC initial enrollment, If someone has Medicaid only and is already in a mainstream Medicaid plan like Metro Plus, it applies to requests for home care to those plans. And in some date in the future, it will be implemented for annual reassessments and requests for increases. The new independent assessment process is really a 3-step process. So the first step is that the New York independent assessor nurse will conduct a nursing assessment, and that can be done in person or via telehealth. Step 2 is that the physician, PA, or nurse practitioner with the NYIA will conduct the medical assessment and order home care if the patient qualifies. And then really, step 3 is that the NYIA decides whether the person is eligible for home care or not. And if they're eligible, the patient's MLTC plan or HRA uses those assessments to determine how many home care hours the patient will receive. Now, I want to make a few notes about this process. So even though I say that both assessments can be done in person or via telehealth, the reports that we've gotten from patients are that the in-person appointments are either not available very soon. Like patients may wait months for an in-person appointment versus a telehealth appointment, which can be scheduled more quickly. So that's something to keep in mind. Another thing to keep in mind is that the New York independent assessor doctor conducting that medical assessment, ordering the home care, is not the patient's own doctor. Can't be the patient's own doctor they use. It's a doctor that's supposedly independent, and therefore it doesn't know really anything about the patient or their medical history. So it's really important to either have the patient or someone with the patient able to explain the patient's medical history, medical condition, etc. So here we have another case example. Miriam is applying for home care for the first time, but unlike the immediate need process I explained, she doesn't need the services urgently. So some questions to think about, whether you know the answers to. How would she start the enrollment process? How long might that process take? And is there anything her own doctor can do to advocate for Miriam? So to start the enrollment process, Miriam should call the New York independent assessor because she doesn't need it immediately. So she's not going to do the immediate needs application to HRA. She's going to call the New York independent assessor. The number is listed there, and say, I need a home care and I need an assessment. Once she calls, they should schedule the 2 assessments, the nursing and the doctor's assessment, and determine whether she's eligible for home care. And if she's found eligible, they should send her a list of plans she can enroll in to get the home care. Now, how long might this process take? Well, unfortunately, there's really no deadlines for the NYIA to conduct these assessments. So they could take as long as they want on the standard time frame to conduct their 2 assessments. Now, plans or the local Department of Social Services, HRA, have to determine the number of hours that the patient will receive within 7 days of receiving those assessments from NYIA. And there's actually kind of a dispute resolution process. If the plan or HRA disagrees with those assessments, they can dispute it and a second assessment will have to be scheduled. So just to recall, the immediate needs deadline is still 12 days after the application is filed. So that has a hard deadline and will move much faster. And then, is there anything Miriam's own doctor can do to advocate for her care? So her own doctor could still submit a letter or other evidence to the plan once she enrolls that she needs a certain number of hours. And actually, another thing we've seen recommended is for patients to have a doctor's letter on hand for the initial assessment so that they can show the nurse or the doctor that evidence from their own physician. Also, if New York independent assessor denies eligibility for home care or the plan doesn't give enough hours, the patient can appeal or request a fair hearing. We'll talk about in greater detail later. So here's a sample assessment tool for home care that the New York independent assessor nurse will use. And basically they'll go through a list of activities of daily living, or ADLs, as well as IADLs. Those are listed on the left side of this chart, and they'll go through that list and they'll determine what the patient's functional level is with that particular ADL. And then all of these data points go into sort of a formula that is supposed to calculate whether the patient needs home care or not. So, for example, the nurse will ask the patient to demonstrate, how they would dress their upper body. Can they, have fine motor skills with their hands? Can they lift their arm? And then determine whether they need the assistance of an aide with that task. And then there's different levels of assistance that can be provided, like you see on the right-hand side. Some people might only need supervision with a task, so like cueing someone to get dressed. Others might need limited assistance, which is guided maneuvering of the limbs, or they might need extensive assistance like weight-bearing support from the aide. And that's really a determination or factor that the New York independent assessor nurse is going to be looking at. So currently, any level of assistance with even one activity of daily living is enough to qualify someone for home care. If the patient only needs assistance with IADLs, or those housekeeping tasks I mentioned earlier, like cooking and cleaning, the patient's limited to receiving 8 hours per week of housekeeping services from CASA in New York City, and they can apply directly to CASA. So another change that's happened in 2023 is a change to how cases are determined where the patient needs more than 12 hours of home care. These cases now have to be referred to an independent review panel. This panel is run by the New York independent assessor, the same organization really for all of these functions. And that panel's job of doctors and providers is to recommend whether that plan of care for more than 12 hours is reasonable and appropriate to maintain the patient's health and safety in their home. Now, the panel is just making a recommendation. They're not making the final decision. The final decision is still made by the plan or HRA. And the patient can appeal if the plan or HRA denies the requested increase. So the next case example we're looking at is for Juana. Juana's children have noticed that she's been losing weight. To try to find out why this could be the case, they stay with her overnight and they notice that she's not been cooking and needs to be reminded to eat. They also notice that she has difficulty lifting her arms to bathe and dressing her upper body, although she does try her best. So under the current standards, which we've gone through, do we think Juana would qualify for home care? Why or why not? So I'll give you just a minute to think this over and think of, if she does qualify for home care, what would the ADLs be that she needs help with? What would the reason be? Okay, so under the current system, I would say yes, she definitely qualifies for home care. I mean, just in the hypo, she needed help bathing and getting dressed. She couldn't do those easily by herself. Now, cooking and eating is a little more complicated of an analysis. So cooking, right, is not an ADL, it's an IADL, unless someone needs a special meal, like low sodium, for example. and then it might count as an ADL. Now, the fact that she needs to be reminded to eat, that actually could be an ADL that could help qualify her for home care, and it also might be a sign that she should be evaluated by a professional for dementia, see if she needs any help in that area. So let's talk about some tools or ways that you can help advocate for patients. So firstly, with the New York independent assessor process, we've seen a lot of problems with the implementation of this process, including long delays in scheduling the medical assessment, up to several months in some cases. The NYIA, representative on the phone might refuse to speak with the patient's authorized representative or POA on the phone, or even hang up the call. And also lack of language access for patients who don't speak English. So it's really important to track these problems so that we can advocate with the state on patients' behalf. So you can make a complaint about the New York independent assessor if one of these problems happens or any other problem happens. So complaints can be filed with the NYIA itself at independent.assessor@health.ny.gov, an email address, or they can also be filed with the New York State Department of Health. And you'll see that there's two different email addresses. One is for people who are in Medicaid-only mainstream managed care plans trying to get home care. And the other is for people trying to enroll in MLTC plans. So we recommend to include in the complaint the patient's identifying and contact information, any details that the patient can remember about the call with the NYIA, and of course, details of the problem that the patient faced. We also recommend including how the patient would like the problem to be resolved. So if, for example, it's a problem with language access, maybe the NYIA couldn't get a Mandarin interpreter on the line, that would be the requested resolution, right? Call the patient with a Mandarin interpreter to make that connection. We've also seen a lot more patients being denied home care at that initial application stage by the New York independent assessor, more than ever before. Before we had this system in place, it seemed like upwards of 90% of patients were approved for home care who wanted it. Now we're seeing many more denials of home care by the New York independent assessor. It's important to keep in mind that patients can and should do two things if they get that home care denial. Firstly, they can file an internal appeal with the New York independent assessor. And the letter that they receive, explaining why they were denied home care should have the information they need as to where to file that appeal. And essentially, someone unbiased, uninvolved with their case at the NYIA should take another look at the assessments and review the determination. The other thing patients can do is request a fair hearing with the Office of Temporary and Disability Assistance, or OTDA. Now, the reason I say and/or is because unlike most hearings or appeals process in the home care system, it's not required that patients file an internal appeal with NYIA before requesting a fair hearing. So they could do both at the same time. They can submit their own medical evidence at this stage, like a doctor's letter or medical records. And as I mentioned earlier, we've heard that at least some New York independent assessor nurses or doctors might review like a doctor's letter or any other medical evidence that patients have on hand during the initial assessment. So just to avoid a denial, it's really better just to have that on hand during the initial assessment and try to get that reviewed. Another type of referral that we receive a lot of besides denials of home care are denials of requests for more hours of home care. So many patients need more hours of home care than they currently receive in order to continue living safely in their own home. When a patient requests more hours than what they currently have, that's called a concurrent review, is the technical term that plans or HRA use. And the patient bears the burden of proof for explaining why that increase is necessary. So medical evidence is really key to receiving the increase. So what we would recommend is that the patient obtain the strongest doctor's letter possible explaining why an increase in home care hours is medically necessary for them. A request for an increase can be expedited if a delay would seriously jeopardize the enrollee's life or health or their ability to basically attain or regain maximum function. And so if it's expedited, it has to be decided within 72 hours. Doctor's letters are really most effective if they're very, very specific as to the patient's needs. Rather than just listing the patient's diagnoses and medications like in a list format, it's better to explain how the specific diagnoses lead to their need for assistance with different ADLs. So as an example, if a patient has dementia, rather than just listing that they have a diagnosis of dementia, it's more helpful to explain that their diagnosis of dementia leads them to need cueing and prompting with feeding, limited assistance with, let's say, changing diapers because they don't know or remember how to do that themselves. Specific details like that. It's always helpful to add the level of assistance that the patient needs with the activity, such as contact guarding or hands-on assistance with walking, for example, if we're talking about a patient who needs help walking. One term that doctors love to use all the time, and we always say, no, don't include that in the letter, is safety supervision. So what you don't want to focus on in the letter is fall prevention or any other kind of safety supervision, like being worried that the patient's going to leave the oven on or is going to choke, while eating, because that's not actually, we're going to explain this a little further, but it's not actually a covered service. But it is good to address any need for cognitive cueing and prompting if the patient has dementia. Some creative evidence that a patient can use in addition to or instead of a doctor's letter if they can't get one to make the case for an increase would be overnight logs. These could be kept by a family member or an aide that they pay. And these could detail how many times the patient is waking up at night and needing assistance. Also, family members or aides can write letters or sign affidavits regarding the care needed. And you can also often get physical or occupational therapy records that show deteriorating functional status. So one thing as lawyers that we look at is what's called the span of time analysis. Now, the idea behind this is that the plan or the HRA must develop a care plan for the patient that meets both their scheduled and unscheduled day and nighttime personal care needs. So that can often be a good way to focus a doctor's letter on what the patient needs. So for example, scheduled needs for personal care assistance could be reminders with taking medications that have to be done at certain times. It could be assistance with attending doctor's appointments, could be assistance with meals. Unscheduled sort of tasks could be help with toileting, help with transferring. And oftentimes during the night, the scheduled task that I'd say is most often needed at night would be turning and repositioning every 4 hours, whatever the doctor recommends. In terms of the patient's bed mobility. And then the most common unscheduled nighttime task we see is help with toileting. So changing diapers or using a commode, for example. Patients are often confused when requesting 24-hour care from a plan with the difference between 24-hour live-in care and 24-hour split shift care. So the easiest way to think about this distinction is that a live-in aide should be able to get 5 hours of uninterrupted sleep, whereas a split shift aide does not need to get 5 hours of uninterrupted sleep. So the real question to ask for a patient who's wanting some form of overnight 24-hour care is, could the aide get 5 hours of uninterrupted sleep? So that's, as a lawyer, what I would ask and what I would look for. And it's really important actually to request the right thing from the plan that you need, like request split shift, because oftentimes if a patient just calls their care manager at the plan and says, I need 24-hour care, and doesn't specify, the plan will interpret that as a request for live-in care because that's a little cheaper for the plan and a little easier for them to provide. So it's kind of a sneaky thing that sometimes plans try to do, and it's a good thing to be on the lookout for. So as I just mentioned, plans aren't required to provide standalone safety monitoring to patients. However, they must make sure that the patient is completing their ADLs safely. So in other words, the plan doesn't have to provide someone to watch over the patient at night to make sure they don't turn on the stove, right? Or to make sure that the patient doesn't fall. But if the patient needs to transfer to their commode at night, an aide needs to make sure that's done safely. So I hope that distinction makes sense. Also, cognitive prompting for people with dementia is covered as a covered service. So for example, a lot of times we see someone who has dementia, perhaps they can transfer and walk to the toilet, but they need to be reminded, to clean themselves or to wash their hands after using the toilet. So that service needs to be provided. So patients have certain due process rights when it comes to any denials of care, denials of a request for an increase in hours. So patients have the right to receive an adequate written notice of any adverse decision that's made by the New York Independent Assessor or by a plan or by HRA. It doesn't matter who's making the decision, they have to provide a written notice to the patient. They have the right to internally appeal any decision that's against them, and also to request a fair hearing of any final decision. Now, pursuant to exhaustion requirements for managed care plans, patients have to request an internal appeal with the plan first before they request a final fair hearing. So that's specific to managed care plans. We always want to, help patients find representation, legal representation for their hearings. And we definitely encourage referrals to be made to LegalHealth or to ICANN or to any other organizations to do so. However, if the patient can't find representation for their hearing, it's important that they gather strong evidence of medical necessity in line with the doctor's letters tips that I provided earlier. And if a patient has a fair hearing scheduled but doesn't have any strong documentation yet, they can ask the judge for an adjournment for the hearing to be postponed to let them have more time to gather the documentation. So on the date that the fair hearing is scheduled, the way these are scheduled, they're scheduled either for the morning or the afternoon. They're all via telephone now. And the patient has to be available to pick up the phone that entire morning or that entire afternoon when their hearing is scheduled. So the judge will call the patient, possibly from an unlisted number. So they need to make sure they pick up their phone on that day. The adverse plan or New York Independent Assessor will present the case first, and then the patient gets the chance to explain why they need home care, increased hours, etc. And the patient should always kind of take the judge's lead, don't interrupt, and answer any questions that are asked of them. Now, before we get to answering any questions, I just wanted to reinforce one thing from earlier in the presentation that I wanted to mention, but kind of forgot, which is that we talked about the scenario where someone with a pooled trust might no longer need that trust because they're eligible under the income limits without a surplus. So now with these increased income limits for 2023, you might also want to identify some people who should apply for Medicaid, but who have been scared off in the past because they didn't think they qualified. Many more people will qualify under the new income limits and should be encouraged to apply for Medicaid. So that way, you know, even if they don't need home care right now, but in the future, they have that all set up and ready for them. So with that, I think Harmony will go through some of the questions for me, and I'd be happy to answer any questions that you have.
Yeah, that was really fantastic. Thank you. So many changes since the previous year when we hosted this training back in June. So excited to answer questions from the audience. Please, a reminder to enter them in the Q&A function under your screen. So the first question is regarding the spend down limit. You have to meet that limit monthly, correct? This means that expenses are applied for that month and that you cannot combine 2 months. Is that right?
So it's a little bit of a complicated question, but I'll try to make it simple. So for community care, so outpatient care, you know, that you need Medicaid to cover, including home care, you do have to meet that month to month. So, you know, you have to submit a certain amount of medical bills that month, or you have to pay in that amount that month. So it is month to month. For inpatient care, like at a hospital, it works differently. So you can kind of do batches of months together, and that's how it works. But for what we were talking about today, which is really home care, yes, it's meeting it month to month.
Great, that's really helpful. Second question is, I think this referred to earlier in the session. How do you request a rebudgeting for Medicaid?
Right. So Medicaid is going to send out a certain rebudgeting request form to every single person on Medicaid. And the patient basically has the responsibility of checking the box saying, I want a rebudgeting, and to send it back in the provided envelope, along with, you know, writing down, right, what their income is this year. Now, if they didn't receive that letter, they could request a copy from HRA, a new copy. They could also probably find the form by looking it up online. In the presentation, which I think you'll all get a copy of, we have the form number. So you could assist them with filling out that form.
Do you remember the top of your head what that form number is, or is it on the earlier slide?
It's
okay.
on an earlier slide, yeah.
Okay, great. Next question is, can you use the pool trust for property?
So the pooled trust that we are discussing for the spend down in this presentation is for income. And that's the only type of trust that we help with at NYLAG. So if a patient has any significant property that they might want to put in a trust, we really always recommend that person to see an estate lawyer, a private lawyer, because that requires specialized advice, and we only provide, you know, services to people who are a little lower income or lower resource. So we don't provide that service. So it is possible to create certain trusts for property, but the patient should see a lawyer to do that.
Okay, great. And then in terms of seeing a lawyer, you have the NYLAG resources at the end of the slide, correct?
Yes.
Great. As we continue on with questions, I am going to launch the post-evaluation survey. Feel free to answer it right before you leave, but we love to learn how you thought about the webinar and hear about future ideas you have. So the next question is, what if a patient is at a skilled nursing rehab during the time of, I'm assuming, application?
Yeah, so an application for home care can be made while the patient is in the nursing home. As I mentioned, they can even apply through the immediate needs process while in a nursing facility to HRA. And honestly, that would be probably the fastest way to get someone discharged home with home care, is to apply for the immediate need process with HRA. And currently those types of requests aren't under the New York Independent Assessor process. So HRA would take care of that start to finish.
Okay, thank you. Are pooled income trusts helping clients to rebudget if they still need the trust, but now have higher income?
So that's an interesting question. So from what I've heard from one trust, no, they're not helping. They consider that the patient's own responsibility. So I wouldn't expect pooled income trusts to reach out to patients to help them request a rebudgeting or to rebudget their trust. Although, of course, if the patient does, rebudget their case and has a lower spend down, they should notify the trust and make that change with the trust, and the trust should absolutely accommodate them and lower their amount.
Okay, good to know. Thank you. What is the best approach or next step for someone who has a pooled trust and with new income limit that may now qualify for Medicaid? So I guess the other end of the question previously.
Yeah, so the patient can calculate the new spend down, and they can ask the trust to make that change, to take out, the lower amount that they really need to qualify for Medicaid. And then when they request the rebudgeting with HRA via that form, HRA will basically retroactively back to the beginning of 2023 configure their income and their spend down amount to be that lower amount.
Okay. Next question is, can patients still go directly to a home care agency who can help with the process?
If the patient needs short-term, what's called CHA services, they can go directly to a provider, to an agency, and get an M11Q form from their doctor and start receiving those services. However, for MLTC enrollment, that has to go through that new New York Independent Assessor process. Great. And so while I don't know if the agency will make a referral for the patient to that process, the patient can also just call that process, an assessor directly to start that process.
So it's up to the home care agency to help them with the
I can't say what a certain I can't say what a certain agency will do, right? If a patient comes to them wanting help, they might make the referral or they might not. But the patient should always call the independent assessor and start the process.
All right. How do you enroll with an MLTC if you already have Medicaid?
So if you have Medicaid and you need an MLTC plan, you call the New York Independent Assessor and basically make appointments for those two assessments. And if they determine that you're eligible for home care, the patient should receive a letter listing different plans that they can enroll in. And then as soon as they have that letter, one of the plans should be able to enroll them and accept them.
Okay, sounds great. This is an interesting one about your experience. Do you have any experience with filing appeals through the Department of Finance through the state?
Yeah, of course. So that's a question that I really didn't get into in the presentation, I guess just because I didn't want to make it too long. But the kind of appeal you're discussing, Department of Finance appeal, is what's called an external appeal. And it's the next step after an internal appeal. So after the internal appeal is denied, you can request the external appeal with the Department of Finance. fair hearing with OTDA, or you can do both, right? A very complex system for patients to navigate on their own.
Mhm.
With every decision, right, that the plan issues denying care, there should be an explanation of this process. So if the plan denies the internal appeal, there should be an explanation of how to file the Department of Finance external appeal and a form to use. Now, we've actually seen some success with these appeals, so I certainly recommend filing that external appeal. It
Mhm.
can't really hurt, and including any medical evidence that you have in your possession. And then just the only thing to keep in mind is that there's a deadline by which you have to request a fair hearing.
Okay.
120 days, don't miss that, regardless
Okay.
of, what happens with the external appeal.
How cumbersome is the appeal versus like the internal one?
I would say it's a little more cumbersome. The form to fill out is longer. Like I said, it's a copy is included. The internal appeal form is very simple, just one page.
Yeah.
But it can be worth doing because it could result in approval of the hours.
Okay, good to know. 120 days. Do they have, or does the finance department have a deadline too to respond to the appeal?
Yes, they do. And so that'll all be outlined in the letter that the patient receives. All the deadlines for appeals will be outlined in the letter. And it's just important to keep track of any of those deadlines.
Got it. Thank you. All right, to transition, do you have any examples for a doctor's letter for more hours? I guess you provided some key language in your presentation, but wondering if you have other resources for that.
Right. So the reason I kind of just provided some key tips for writing a doctor's letter is because every patient's situation is going to be so different. So I do, in fact, have a lot of copies of doctor's letters that are sort of for different situations. So like I might have a copy of one that is for a dementia patient that needs help with toileting, and another one for someone with, physical disabilities, right, that needs help walking. And so if you wanted to reach out, I could probably provide you some redacted samples of letters. But I just didn't include that because each case is so individual.
For sure. I think the general blueprint you provided in your slides is really helpful. Like, due to this diagnosis, the patient will need help with XYZ ADL. So thank you for that and offering for providing other examples. I think the email is in the presentation. If not, I could send it to the attendees here. And it's also just really interesting that doctors should avoid language on falls prevention.
It's in almost every letter I've seen from a doctor that they write. And it's not that it's going to hurt, it's just not going to help the person get the hours.
Well, that's really helpful. Can you share a document listing the ADLs and levels of care?
That's a good question. Actually, I'm sure I could. I just had like a little snapshot kind of the assessment tool, but I do have a full sample assessment tool that I could share if people are interested.
That's great. Have you seen NYA complaints actually result in an appropriate response or solution?
So complaints to the Department of Health can result in a solution. Okay. I haven't seen the internal complaint result in anything yet. So it may be worth going to the Department of Health in these cases.
Great. This question might be in context to some point in a later slide, but could we do the rebudget earlier? I don't know what earlier means.
So I think maybe earlier before the letter goes out from HRA. I mean, you can request a rebudgeting at any time. I just don't know if they're really going to consider those on an earlier basis or just kind of batch them all,
Okay,
But you could use that form and request it.
okay, thank you. Let's see. Everyone has really great questions. Thanks, everyone. If the assessment is completed by an independent assessor, do we still need to submit an MQ or M11Q or CDPAS to the insurance plan?
No, they shouldn't require that because it's kind of been replaced by the NYIA doctors, like assessment / order for home care.
Okay. How do you apply for CASA home care?
Okay, so CASA provides home care to immediate needs recipients. And also to certain people like excluded from MLTC enrollment and people just receiving housekeeping. So I think I mostly covered the immediate needs process. So if you need like full home care through the immediate needs process, you can apply to HRA directly using that process and fax number on the slide. If you need housekeeping only services, there's a list online of each borough's CASA office, right, that you can reach out to.
Okay, thank you.
If you just Google like CASA borough list.
Okay, CASA borough. What happens, if anything, when a person dies and there's a balance in the pooled income trust?
So the descendants or the recipients under the will not get any balance left over in the pooled income trust. It basically will go to pay Medicaid back, and then anything left over will go to the trust itself. So that unfortunately won't go to any of their family. So that's why we always recommend that patients spend the money each month that's in the trust and don't let that money accumulate.
Great. Quickly back to CASA. Do CASA recipients get transferred to MLTCs after a certain time?
Yes, they do. They do. So after 120 days of receiving immediate need care through CASA, they'll get a notice saying that they have to join an MLTC plan. And they're going to get 90 days transition rights, right? Where they receive the same amount of hours in the plan that they choose.
If people haven't filled out the poll that should be on your screen, it's called post-learning evaluation. That would be so great. We still have time for some questions. Let me see if we consolidate any. Here's a quick one. The letter for rebudgeting should be sent around April, right?
So the renewals will start again in April for the Medicaid, annual recertifications will start in April. And I'm not sure if the rebudgeting letter will be sent at that same time or if it will be sent a little earlier or a little later. So that's a great question. Something I should.
Oh, all right. I'll follow up with you. Are benefits to applying for home care without immediate need, given that assessments can take a long time, versus waiting to apply with immediate need then, or when assessments need to be done within a certain deadline?
So, for using the immediate need process, the patient does need to be able to attest that there is an immediate need for home care. So it's kind of a factual question, right? Is that really the case or not? And it's kind of for each patient to decide. I mean, a lot of people use the regular process, and I'll say that it can be a little bit easier actually to just go through the NYIA and enroll in an MLTC plan through the regular process, because you don't need to compile all of that paperwork like the attestation form and the M11Q form from the doctor. And, you know, HRA and CASA, they're very picky when they're looking at those M11Q forms from the doctor. So if anything's not filled out, they might reject it.
This is a question from me. Are there any data tracking how many appeals are made, how many rejections are given out? Because you mentioned advocacy through the appeals process, but I'm interested in your thoughts there.
That's a really great question. So the short answer is that there's none that I know of. Now, Department of Health does collect all sorts of data. Some of it they make publicly available and some of it they don't. At NYLAG, the Evelyn Frank Legal Resources Program has a MLTC transparency project where they list some numbers from DOH, but that's a little more focused on, I believe, managed long-term care plans. And the state does make data about those plans publicly available. So I don't think that focuses on the independent assessor denials, but great question.
Okay. For someone who has a diagnosis of obesity, schizophrenia, who also has difficulties with ADLs, is refusing home care. If this is a case, can the provider change to allow the client to receive these services?
Right, so clients can switch MLTC plans or managed care plans. There is a certain sort of lock-in period, but generally speaking, clients can switch plans and often do. They can contact new plans on their own to see how many hours that plan would be willing to provide, and then make the switch through New York Medicaid Choice. So they absolutely can switch agencies if they don't want to like do the appeal process instead.
Okay. We have a few more questions here. You mentioned that with HRA retroactive for pool trust, does that mean if extra money was taken by the pool trust, can this overcharge be given back to the patient?
Okay, so great question. I believe, I haven't run into this problem with a specific patient or a specific case, but I believe the answer would be no. And I'll explain why. So pooled income trusts are all irrevocable trusts, meaning that once that money goes in, it can't come out or be given back to the patient. Now, that's why I was recommending that if the patient knows what their new spend down amount would be, they can go ahead and ask the pooled trust to make that change and decrease the amount they're taking out now, and then request the rebudgeting from HRA. And HRA will then, you know, retroactively rebudget the patient.
Mm-hmm.
If the patient, you know, waits and gets the rebudgeting from HRA and then changes the amount that's being taken and put into their pooled trust, I don't think there would be any way really to recover that amount back to the patient, because like I said, the trust agreement is irrevocable. However, the patient should, you know, use that money to pay any kind of bills that they have accumulated.
Okay, thank you. Is there a specific process to follow if a patient who already receives home care wants to switch to a different LTC company?
Yeah, I kind of just answered that. So I'll just, again, like patients can switch, they can contact the new company that they're interested in joining. They can reach out to more than one, see which one offers the most hours. And then that company should assist them with making the switch.
Great. I'm not sure what this last question is saying, but has Medicaid changed, or is it more feasible to be approved? I think you covered that generally in the beginning of retention, but yeah, I guess what are your general impressions?
Yeah, I guess that's actually a good kind of overall takeaway would be that home care actually now with the independent assessor process might be more difficult to get than ever before. However, Medicaid is now easier to qualify for with the higher income and asset limits. So it's sort of a double-edged sword in terms of the 2023 changes. There's good and there's bad.
That's a great way to wrap up. Thank you so much getting through a ton of questions. As always, thank you for those who attended and being a contribution to a lively and engaged audience. I'm going to share my screen for a list of future events and trainings that we have around the corner. On Thursday, February 9th, we'll have an overview of SSI and SSDI benefits. On the 14th of February, we'll have a training or overview of the eviction prevention after 1 year for the ending of the moratorium. We'll go over adult care facilities in February 22nd. We'll have an immigration as a social determinant of health training in March, and then be on the lookout for an event we host with the Health by Housing Lab at NYU called Flipping the Script, a teach-in with homeless older adults. With that, I will keep the poll open a little longer. Again, thank you, Sarah, for this great training. And thank you everyone for coming today.
Thank you, everyone.